Okay, before we start with myasthenia gravis, let's review how our muscles work. So here, under physiology. So we need neurotransmitters, yeah, for muscles to be stimulated and for them to move. So there are two things usually responsible for that. We have acetylcholine, okay, that's a neurotransmitter, and we also have dopamine. So acetylcholine is, here's the picture. So let's look at the left side. So this is the nerve ending, and then this is the neuromuscular junction. Okay, this is your muscle, and this is the end of your nerve. So there's constant production of acetylcholine. Okay. And then they're passed from one end of the nerve to one end of the muscle, and then so on. Right? For us to be able to control muscle movements, that's where dopamine comes in. So we learn about dopamine and dopamine deficiency next semester under Parkinson's disease. So let's focus on myasthenia gravis. So if the number of acetylcholine equals the number of receptors, any question about that? So here are our acetylcholine. These are the receptor sites. Okay, meaning each molecule of acetylcholine must be received by a receptor, right? And then the signal is, the impulse is transmitted. Okay. And again, if there's an equal number there, then that's great. All right. So we can sustain muscle movements however we want, okay, depending on how much energy you have, no problem whatsoever.
Professor Scott,
Yes.
on your laptop, there's a settings where you could do that where it's not going back to the screensaver,
No, it's not the screensaver. It's the
Oh, it's that
Apple
doing that.
TV.
I
Yeah.
was wondering why it keeps going back to.
No, it's not my screensaver.
Oh.
It's the signal, the
Oh.
Apple TV. Keeps cutting out. So here we have, again, if we have an equal number of acetylcholine and receptors, muscle movement will be sustained. Okay, we can jog, we can eat, we can chew, we can swallow, we can talk. Okay, so no problem. Breathing is okay, all right? So every muscle movement is sustained. There's no weakness whatsoever. The problem in myasthenia gravis is it's an autoimmune disorder. What do we mean by autoimmune? Right, so our autoantibodies are destroying some body part, right? So it's destroying our own body, okay? Not the entire body, but specific areas. So in this particular problem in myasthenia gravis, we have antibodies that are destroying the receptor sites, okay? So here, the problem is there's no problem with acetylcholine production. The problem is the antibodies. Look at the picture on the right. So the antibodies destroyed the receptor sites. Not all of them, but about half or even more than half of the receptor sites have been destroyed. They've been identified as foreign and destroyed by those autoantibodies. So now what? We have enough acetylcholine, but not enough receptor sites. So what happens with muscle movement? Can we sustain it? No, because the transmission is, well, there's still transmission, but not right, not continuous. Okay, so we cannot sustain, therefore, a muscle contraction. So we get weak, and then you get weak enough that you can't move anymore. Okay, so you have to stop, and then it's relieved by rest, though. Okay, so this one particularly affects repetitive muscle movement. So what are examples of repetitive muscle contraction?
Exercise.
Well, something basic like because I don't run. Yeah, I walk, but I can, I can sit. But what's something we need to do? We need to do continuously. Chewing, right?
Oh,
Yeah, when you eat a meal, can you finish a meal? Yeah, chewing and swallowing is continuous, yeah? When you eat a meal, so you eat, swallow, eat, swallow. Can you sustain that if you have myasthenia gravis? Can that be dangerous? Yes, because if the weakness occurs right before swallowing, can you choke?
Yeah.
Yes, that can be a problem. Or what else do you do repetitively? Name a job, for instance, like mine, I talk. So what do you guys do? That's something repetitive in your job.
Communicate by speech.
Okay, if you're a public speaker, for instance, right? Or what about typing? Yeah, so if you're, let's say, a data encoder or some sort, okay, you use your fingers a lot, that can affect your job. What about breathing? Is that something repetitive? Yes, unfortunately, we need to continuously breathe, so that will be affected as well. So there's weakness with every repetitive muscle movement. So you name walking, jogging, for instance, typing, chewing, eating, even talking. Okay, so that requires continuous repetitive muscle contraction.
So Professor,
Yes.
how would the patient, signs and symptoms, like how would the patient look? Will they just not be able to?
Well, it's not going to be that not dramatic.
Yeah,
Okay,
those
yeah,
people.
not like that. But the patient will have
Trouble.
problems. Yeah, they'll
Okay.
have problems functioning. Okay, so the earliest symptom is another frequent muscle contraction, which is blinking. So we were not conscious about it, but we actually blink several times a minute. Okay, the only time, of course, if you're sleeping, then you're not blinking. So here, the earliest manifestation is double vision and eyelid drooping. So these are the earliest manifestations. And this is usually what causes the patient to go seek attention. Okay, so they can't hold their eyes open. That's the problem with myasthenia gravis. So that's the earliest manifestations. And then there will be weakness of the bulbar muscles. Bulbar muscles are those responsible for eating, chewing, swallowing, and speaking. Those are bulbar muscles. And then there's respiratory weakness as well. Dysphonia now, and then the most life-threatening would be the dysphagia. A patient will have choking episodes as a result. Then I said again, breathing will be affected here. Wait a minute, I have to make a call. Let's go to testing now. Let's look at two scenarios because the testing can be done in one of two scenarios. Let's say Gabby has manifestations of myasthenia gravis. So she has the diplopia, ptosis, she has weakness, she's been choking a few times, she's been having trouble breathing, she can't function at work. So she finally decides, okay, I'll go see my doctor. So when she discloses symptoms to her doctor, doctor says, that sounds like myasthenia gravis. Let's be sure. So the doctor will perform a Tensilon test. Tensilon is spelled Tensilon. Tensilon is the brand name for edrophonium chloride. So a Tensilon test or edrophonium chloride IV is done to diagnose myasthenia gravis. Okay. So was Gabby already receiving treatment before she came? Not yet. So she didn't even know she had myasthenia gravis. So she comes in to do the test. Doctor performs the test. He or she injects edrophonium chloride. Now, edrophonium chloride is a short-acting cholinesterase inhibitor. Okay, so let's go back. What is a cholinesterase inhibitor? Let's go back to the anatomy and physiology. So for muscles to be stimulated and contract, what do we need to happen again? Okay, so we need adequate amounts of acetylcholine and equally adequate amounts of acetylcholine receptors. Okay, what do we need to have in order to stop muscle contraction? Because yes, we want muscles to contract, but it has to stop at some point, yeah? What makes it stop is what we call cholinesterase. So what is cholinesterase? It's another enzyme which will destroy acetylcholine. It's a natural process. Okay. So if we have acetylcholine, we must also have cholinesterase, because otherwise, will the muscles ever relax? No, the muscles will contract forever. So in order for the muscle contraction to stop, we need cholinesterase. Okay. So where does cholinesterase enter the picture? So here in testing, here, acetylcholinesterase, or we can also call it cholinesterase. So a cholinesterase inhibitor cholinesterase will destroy acetylcholine, correct? Okay. So if you give a drug that will inhibit cholinesterase, what will happen to acetylcholine? Acetylcholine will not be destroyed. All right. So why does the patient's facial weakness, the eyelid drooping, resolve after 5 minutes after injection of edrophonium chloride? This is what happens. So yes, the patient has myasthenia gravis, correct? What does the patient have again, or don't have? The patient doesn't have enough acetylcholine receptors, correct? So this is the problem. This is what Gabby has now. So that's why her symptoms are present, because she doesn't have enough receptors. They've been destroyed already. Can you resurrect something that's been destroyed? No, Gabby, that doesn't work like that. We can't make new receptor sites. They've been destroyed already. So all we can do is, even though there's enough acetylcholine, we don't have enough receptor sites. Plus, we have what again? That will destroy acetylcholine? We have cholinesterase that will destroy acetylcholine. So what we did was, during testing, we gave Gabby a cholinesterase inhibitor, which will prevent acetylcholine from being destroyed. So even though we don't have enough receptors, because you did not destroy acetylcholine, will this now make up for the loss of acetylcholine receptors? Yes, because you're not destroying the acetylcholine, you're making them available longer, because they're naturally destroyed. So it's a natural occurrence that when you have acetylcholine, when you're transmitting it, it's also destroyed at the same time. So if you prevent them from being destroyed, can this now make up for the inadequate receptor sites? Yes, so now that's why Gabby's strength increased after injection of edrophonium chloride. Any question about the testing? Any question? All right, so this is now the goal of therapy. Because she responded, the doctor diagnosed, this is a positive tensilon test. You have myasthenia gravis. So now she'll be prescribed an oral cholinesterase inhibitor forever. Any question about that? We cannot, however, use edrophonium chloride because edrophonium chloride is IV, plus it's short acting only. It only has a half-life of a few seconds. Any questions? So can edrophonium work for long-term therapy? If it only has a half-life of a few seconds?
No, not gonna work.
You're right, because otherwise we will keep eating it forever, right? Non-stop, even if we're sleeping. So this will not be used for therapy. This is only used for what? Testing only. That's the only use for edrophonium chloride because it only has a very short half-life, which can be actually good. We'll talk about the other scenario later, okay? So now we have a diagnosis of myasthenia gravis. So what do we do? Okay, so we'll treat her with cholinesterase inhibitor. So the drug usually prescribed here is pyridostigmine. Other choices are, especially if the patient's symptoms, so let's say Gabby has a flare-up, she has severe symptoms of myasthenia gravis. She's now in respiratory failure. She's unconscious now. So these are the other options. So we'll give her one of a few immunosuppressive therapy, either IVIG infusion. These infusions, intravenous immunoglobulin, are very expensive. Let me give you an idea. It's based on your weight. Plus, last time I checked, okay, this was 10 years ago. The cost of IVIG per gram is about $1,500 per gram. And it's based on your weight. So how much is that if you weigh 70 kilograms? So 70 kilograms times 1 gram per kilogram times $1,500. How much is that? That's tens of thousands of dollars per infusion. It requires about three infusions a week. So how much are we talking about here? Hundreds of thousands of dollars. Okay. So if you have good insurance, great. What if you're not insured? You're up the creek, right? Another option, cheaper option, is plasma exchange. I'll discuss plasma exchange a little bit later because it's in a different section. Plasma exchange is we take out your plasma. Why? Why are we removing your plasma and then giving you somebody else's plasma? Okay, so as we discussed earlier in lab, what does plasma contain? Besides clotting factors, antibodies are there. The bad antibodies are in your plasma. So what we'll do is remove your plasma and give you somebody else's plasma, right? And then thymectomy. Now, thymectomy or removal of the thymus gland will only work for a very small percentage of people with myasthenia gravis. About 1 to 10% of people with myasthenia gravis has a tumor in the thymus gland, and that's usually what's causing the patient's symptoms. But because it's only affecting 1 to less than 10% of the patients, so it's not an option for everybody. There's no cure for myasthenia gravis. This is only lifelong treatment. That's all we can do. Which is the same, which is also true for all autoimmune disorders, yeah? Have you heard of an autoimmune disease like lupus,
Yes.
Crohn's disease? Do they have a cure?
No,
No.
it's chronic.
Wrong classroom. Wrong classroom.
This is nursing.
All right, here's the drug therapy now. So the most commonly administered drug is pyridostigmine. So this is oral anticholinesterase or cholinesterase inhibitor. The dose is gradually increased because the patients, do we all have the same activity levels?
No.
Like I'm a gym rat.
You are?
Yeah. It's not obvious.
Buffet. No, I'm just joking.
So we have different physical activity levels, yeah? So we will have the same, let's say all of us have myasthenia gravis. We will have the same doses. No. So those who are more physically active will require higher doses. Okay. So usually the dosing, since it's not the same, it's always adjusted per patient. Right? So it's unique to every patient. The doctor prescribes the dose based on their activity levels. There is a IV option. Let's say this patient, let's say, becomes hospitalized or is unconscious. Can they take pyridostigmine by mouth? No. So the IV option, which is still long-acting, unlike edrophonium, is called neostigmine. Just replace the pyrido with neostigmine, NEO. That's the IV form. right, of long-acting anticholinesterase agents or cholinesterase inhibitor. Also, during a flare-up, because these patients can have exacerbations, they can have flare-ups, steroids can also be used for short-term steroids. And when we do that, we give them prednisone, and then we always taper steroids, right? So same applies here. Again, IVIG, the expensive option, is used during exacerbations. But because it's very expensive, most people will have plasma pheresis or therapeutic plasma exchange. Okay, so let's discuss this now. So what is plasma exchange? Remember dialysis, hemodialysis? So how did we do hemodialysis? Right, so we needed an IV access, correct? To remove the patient's blood, put it into a machine, right? Just like a dialysis machine.
Yeah.
Yeah. So it
keep interrupting us. It's just not right.
Come out the door, just push the button.
yeah, that's right. So let's repeat. Let's start over. So how does plasma exchange work? So it works just like a dialysis machine, hemodialysis machine. What did the hemodialysis machine do? Okay, so it took the patient's blood, and what did it do while the blood was in the machine? Remove excess water, excess waste products, excess electrolytes, yeah? So here, the same principle, but since this is called plasma exchange or plasmapheresis, this term here, plasmapheresis, what is this machine removing? Plasma. It's removing plasma. Okay, it can't selectively remove antibodies. It either removes a substance or nothing. Okay, so it's not that detailed. It's not powerful enough to just check out the white blood cells, okay, or the antibodies. Sorry, it will remove the entire plasma. So since we're removing plasma, we have to replace it. Yeah, so the patient will receive a plasma transfusion at the same time. Does that make sense? Okay. So again, the patient, of course, will require an IV access, or let's say it's an emergency, they'll have a dialysis catheter, a central line for plasma exchange. Any question? All right, so that's how it works. There are complications though for this procedure, because what else does plasma again contain? Because the entire plasma of the patient is removed. So what else are we removing besides autoantibodies? The good antibodies are also removed. So what could be a complication because of that? Infections, right? Patient will be prone to infections. What else does plasma contain? It also contains protein. So what will happen to the patient's protein levels? What will happen to their blood pressure? Low. Blood volume will be low. And then finally, the patient also has, what else does plasma contain again? So it has protein, antibodies.
Hemoglobin? What is it?
Clotting factors are there, right? Yeah, I showed you on the table earlier. So there are clotting factors in there, but you removed it too. So what will another complication be? Bleeding. Okay, patient will have bleeding problems. Okay, so those are your complications as a result of this procedure.
That would affect also erythropoietin, right?
No, because erythropoietin is from the kidneys. All right, any question about this procedure? Okay, let's move on. Another option is surgery. Remember thymoma? Okay, so only a small portion, again, of the patients with myasthenia gravis have a tumor in the thymus gland. So if that's the case, then they will undergo thymectomy. There's not much here for this procedure. I mean, it's a small gland here, right, in the sternal notch. There's not much pre and post-op care related to this. Let's go now to complications of myasthenia gravis. There are two types of crisis here. So we can have a myasthenic crisis or a cholinergic crisis. Let's talk about myasthenic crisis first. This crisis is caused by inadequate cholinesterase inhibitor. Meaning, remember earlier, do we have a fixed dose for these patients?
No.
No, because it depends on their activity level. So the higher the activity level, then the more doses they will get. So obviously, did this patient increase their dosing if they had an increase in their activity level? Obviously, no. Okay, so as a result, the patient went into a myasthenic crisis, meaning this is a severe form of myasthenia gravis. All the symptoms we talked about earlier, all those weakness, respiratory weakness, swallowing, blinking, and muscle weakness, all of them are increased. So the patient here will be generally weak and they may go into respiratory arrest because they can't breathe. Okay? The diaphragm is severely weak. So there's usually a
No,
so what can cause myasthenic crisis besides not taking enough dose? Well, it could be that their doses may have been appropriate, but they did not anticipate pregnancy, surgery. Okay, so these events, what will happen to your medication needs here? You need higher doses, yeah, because you have a higher need. Okay, so the patient therefore goes into a myasthenic crisis. So let's go to management now. So what do we do if a patient has myasthenic crisis? Before that, let's talk about the cholinergic crisis first. So we know what is the nature of myasthenic crisis again? Enough or not enough cholinesterase drug? Okay, not enough. There's inadequate, not enough medication. Let's go to the cholinergic crisis. It's not mentioned here, but we have myasthenic crisis. Okay, so a cholinergic crisis is the opposite. Patient had too much of the cholinesterase inhibitor. The problem is the manifestations are identical. Patient has severe weakness as well. So can we tell them apart easily? Not very easily. So in order to tell them apart, let's go back to Tensilon testing. Right here again, let's do another Tensilon test. This time, was the patient already previously taking anticholinesterase medications? Yes, this time the patient was already taking pyridostigmine, okay, on a daily basis. Can we tell myasthenic, which is not enough medication, versus cholinergic crisis, which is too much medications? Can we tell them apart easily? No, they look the same. So think about it. If we perform the Tensilon test and we give them the short-acting edrophonium chloride, if the patient has myasthenic crisis, what will happen to the patient? They'll get better. Strength will improve. However, what if they already took too much cholinesterase inhibitor and are in a cholinergic crisis? If you give them edrophonium, what could happen? Gabby, you said?
toxicity too much.
And? they could die. Okay, the patient's condition will get worse. Because remember, in cholinergic crisis, what's the problem? They already took too much. Now you're gonna add more anticholinesterase agent in the form of edaponium chloride. So if the patient is in cholinergic crisis and you perform this test, can the patient die? Yes, the antidote must be made available. So if you're doing the test to distinguish between a myasthenic versus a cholinergic crisis, what drug must you have ready? Atropine. Any questions? Okay, so this is now the scenario. Okay, so again, diagnostic procedure, first time diagnosis, no cholinesterase inhibitors involved yet. Do we need atropine? No, because there's no danger of toxicity because the patient wasn't even taking the cholinesterase inhibitors yet. But if we're trying to distinguish between myasthenic and cholinergic crisis, what do we need to do when performing a tensilon test? Atropine must be ready. Any questions? All right, let's finish the complications. So again, a cholinergic crisis is caused by over medication. So during doesn't really matter whether it's cholinergic or myasthenic crisis, the patient is intubated because again the manifestations is the patient has respiratory failure, right? So they can't breathe, the diaphragm is extremely weak, so they're intubated, put on a mechanical ventilator. Now if this is the scenario, if the patient is intubated, read this please.
Antonio. Cholinesterase inhibitors are stopped. Whoa. Home sharing. Cholinesterase inhibitors are stopped when respiratory failure occurs and gradually restarted after the patient demonstrates improvement for the course of therapeutic plasma exchange or IVIG.
Okay, any question about plasma exchange or IVIG? What's the difference again? Yeah, this is this is the antibodies. Okay, so you're giving good antibodies to the patient. Yeah, plasma exchange. So what is this? Describe that.
It's putting in antibodies and
Plasma. Putting in plasma. Yeah. And removing the patient's plasma. Okay. Okay, the reason for not giving cholinesterase inhibitors when they are intubated is this drug, one of the side effects is it thickens the secretions. Opposite. What is the anticholinergic? You still remember this from pharm? What is the effect of anticholinergic drugs? They dry you up, right? Dry mouth, yeah, urinary retention, blurred vision, confusion, yeah, tachycardia. So this is the opposite. These cholinesterase inhibitors, therefore, will cause thickening of the secretion. So that's why they don't give it when the patient is intubated. Are we clear? Now, patient's better because remember, what do we do when the patient has a flare-up, when they have a crisis? What is being given? You just read it. Plasma exchange or IVIG. Okay, that's the treatment. Or steroids, correct? So those are the treatments for a flare-up, for an exacerbation. Okay, so here's a warning teaching for the medications. Thank you for reading. Mr.
Maintenance of stable blood levels of
Cholinesterase.
Medication is imperative to stabilize muscle strength. Therefore, the anticholinesterase medications must be given on time. Any delay in administration of medications may exacerbate muscle weakness and make it impossible for the patient to take medications orally.
Very good. There are promising medications. Have you seen a commercial on TV? They have a antibody monoclonal antibody. They're advertising it on TV. It's an IV infusion treatment for myasthenia gravis. So that's new. Okay, it didn't make it to our textbook yet, but since they're advertising it on TV, so it may be on the next edition of the textbook already. They always do these with autoimmune disorders. Just like Crohn's, psoriasis. You see them on TV, right? I mean, you have these Sotyktu. Like nothing is everything. You see those commercials? So those are for those autoimmune disorders, right? They're expensive, but that's why they can afford $1 million ads. Those ads on TV, they're like $1 million a pop, okay, for like 15 seconds commercial. That's yeah. Yeah, exactly. So they're expensive. That's why they can afford those commercials on TV.
So recap, from for the myasthenia gravis, we give high, what's that, the medication, high sausage.
So far, pyridostigmine. Where does that come from? Okay. All right, and that's it. Those are your maintenance medications.
Oh, that's maintenance.
Yeah, so right here. So that's what they're talking about here. So Mr. Valadares just read this. This is for pyridostigmine. It must be taken on time.
Oh.
All right. And here's the another reason. So the patient doesn't choke. So how long should they take? How long before a meal should you take the medication? About 45 minutes to an hour. Okay, that way the drug is already peaking when you start eating, so you don't choke. Okay, so you can sustain the activity. And please read the rest. Here, for instance, if your patient has some vision problems, I mean, they can't close their eyes and then take care of the eyeball because they will be dry. Oh, which means reminds me of one thing also. Remember in hyperthyroidism, the patient had exophthalmos, correct? They had eyes like this.
Yeah.
Okay, so same thing, because can those patients close their eyelids fully?
No.
No, right? So they will have dry, irritated eyes, correct? Okay, so to prevent injury, so similar here, if the patients cannot close their eyelids fully, what do you think will be done? Can we do eye drops? Yes, we can give eye drops. Can we also help the eyelid close, especially when they're sleeping? Yes, so we can tape them. Okay, so you can, it's not like there's no eyelid. The eyelid just retracted. So you can put tape, like masking tape. Okay, and then you can tape the eye close. Okay, or you can put eye patches. Okay, that will also help reduce drying of the eyeball.
But the sunglasses, I mean, the eyeglasses, you're saying it's good, right?
Yeah, but I mean, you can't wear sunglasses all the time. Plus, you'll have to explain it. Let's say you're in class, you have to explain it to your teacher.
It's accepted, right? I mean,
No, just to moisten the eye. Because remember, there's a problem with blinking.
Yeah.
Okay, both for this patient and also for the hyperthyroid patient. Same problem. And here, patching of one eye. Because remember, one of the symptoms of myasthenia gravis was double vision. So patching one eye can help with the double vision. And then reminding them of the triggers, what will precipitate a flare-up, an exacerbation. And remember, some things they cannot really avoid, surgery, illness, pregnancy. And here are for patients who have advanced conditions, no, we cannot manage their symptoms well, they may benefit from feeding tubes already, rather than risk aspiration and aspiration pneumonia. Here's also, this is also the same. I also missed this under hypothyroidism. Hypothyroidism and myasthenia gravis patients are both especially sensitive to CNS depressants. Because in hypothyroidism, remember, their drug metabolism is also slow, correct? So if you give them CNS depressants like opioids, for instance, let's say sleeping pills, yeah, benzodiazepines, what could happen to those patients? Yeah, because the drugs will not leave their system normally. So it will be toxic, can be toxic. So same thing with these patients as well. Any questions on myasthenia gravis? Yes. Not really. I'm even surprised why they bothered with those TV commercials, because they're not really that many myasthenia gravis patients. Okay, but I guess there's enough for them to spend, money on those commercials. So I guess, yeah, there's, but not really like diabetes or heart. I know that's everywhere. Okay, it's not that common.